Very good morning. I think Shalini is in the traffic, so I have to give the first talk. I would not like to bore you much. You all are renowned hepatologists and treating for many years. This is a thought process which came to me just when I heard a talk from Senil around 4-6 weeks back, that are we missing out something when we are diagnosing patients with MASLD or MAFLD? We certainly are not at this institute, because we do a lot of, related investigations and try and find out how better we can manage this patient. But all over the country and at other places, I think they are missing out on some of it. And when he's talked about adipose tissue being the big fatty, daddy of the liver, that was the stimulating talk, which made me think that let's look into some literature and see what can be done. And I certainly came across a couple of good articles published this year only. So we know that metabolic syndrome is a constellation of insulin resistance and primarily a lot of cardiovascular risk factors and a systemic metabolic dysfunction, primarily driven by dysregulation of adipose tissue. So this manifests as adiposopathy, which I've heard a lot of time here, a talk by Professor Sareen and others. And this expansion of adipose tissue, which is pathogenic, and ectopic fat distribution in your vital organs, and altered, consequently, secretion of adipokines and hepatokines, that causes this dreaded disease, or what you call as MASLD. Look at this picture. There are two patients who have almost similar profile. The BMI is good, their body fat mass is similar, the age-wise is okay, but look at the fat distribution here and here. The visceral adipose tissue is much, much more marked, and that's what is reflected in the biopsy as well. And that is what is happening in these patients. So I will talk about, give you a brief outline of what is the current MAFLD scenario, what is the nomenclature I am talking about, why, and what is this visceral fat deposition and pathophysiology, what are the organ dysfunction which are occurring due to fat, how and what to investigate, can we have a grading what has been proposed for this new syndrome when MASLD is the prototype of the patient you see, treatment plan and way forward. So we know MASLD has prevalence almost 1/3. Population is having this. Asia may be having more. And we project by 2030, 3 billion adults may be obese. And we have 50 to 80% having associated metabolic comorbidities. And it is an independent risk factor very well established for cardiovascular mortality, sarcopenia, and chronic kidney disease, and huge cost. Now, if you look into one of the study published recently in, I think, 2023, 202 patients of MASLD followed for 8 years, a mean of around 7 years. Those who had biopsy proven every 6 to 2 months, and they had a lot of these problems, including steatohepatitis, diabetes. And what was the mortality and outcome? Highest mortality was cardiovascular, 2.03, vis-a-vis liver-related events, the malignancy. So it was much, much more with cardiovascular mortality, and that is what we need to rethink about when we are managing. Another meta-analysis of 129 studies, and they found that clinical outcomes were equal. When they did a subgroup analysis, they found that when they do a subgroup analysis, there was no statistically significant difference in longitudinal risk for incident of cardiovascular disease, diabetes, cancer, and chronic kidney disease in these patients of MASLD. Having said that, a term came 2 years back of cardiovascular kidney metabolic syndrome, very well defined now by American Heart Association in 2023 guidelines. But look at this cartoon. There is absolutely no mention of liver here. Not to say that they did not. They do talk about MASLD or MAFLD in that, but it is not mentioned here. Not to say that it is a matter of. So the new nomenclature is, we know this, can it be cardiovascular renal hepatic metabolic syndrome? Or can it be cardio-renal diabetes liver metabolic syndrome, cardial MS? Why I am saying this? because at the core of all this is weight gain and dysfunctional adipose tissue, metabolic risk factors and markers of risk which you see in these patients, cardiometabolic diseases and kidney diseases, and advanced cardio-renal liver metabolic disease, what you would see in years to come. And integrating MASLD as a pivotal component is very, very critical. I will narrate in few further slides. The significance is you try and create a model where you transition a patient from reversible metabolic disturbances to irreversible organ damage. Early intervention, so you target tissue health and ectopic fat deposits. Also, this offers you as clinicians an actionable paradigm for risk stratification, timely diagnosis, and personalized prevention strategy. And I'm very happy that 2023 ASLD guidelines, as narrated here, talk about all this. Similarly, even the FSL, which is more exhaustive, also talks about all these risk factors and way to handle them. So there are guidelines, but what is the practice? That one needs to see clearly. And do they need further refinement? So pathophysiological links between MASLD and extrahepatic complications. There is primarily inflammation and fibrosis, insulin resistance, gut microbiota, dyslipidemia, genetics, hepatokines, and visceral fat, which needs to be looked into more extensively. We know about fat for last 2 or 3 decades. There are a lot of papers on these fat deposition. So what is the reason for fat deposition? The simple is you may have a genetic predisposition of unfavorable, what you saw in that lady when I showed you, equal BMI, everything okay. Increased availability of the dense energy food which we have for last 3-4 decades or 5 decades. Reduced physical activity, environment, and when this subcutaneous adipose tissue expansion capacity is reached, it gets deposited. You all know that in these vital organs. So cardiac MS reframes metabolic syndrome as a continuum of interconnected organ injuries rather than isolated risk factors, what you see in metabolic syndrome. So you have these risk factors, you have these 4 or 5 ATP3 or guidelines given. So fat distribution in body we know is primarily at these places. Luckily, the subcutaneous adipose tissue is by and large neutral, and the gluteal fat is probably helping you in decreasing the risk, but the increased problem is because of visceral fat, which has associated insulin resistance and metabolic syndrome. And this UK Biobank study of around 40,000 individuals adjusted for BMI very clearly showed that when you measure this fat by CT or MRI, you find this to be an independent risk factor for diabetes and other cardiometabolic morbidity. So what is the role of hepatocytes in induction of inflammation and insulin resistance? So primarily hepatokine is involved in this inflammation. And another experiment in mice, when they induced obesity, they found that hepatocytes synthesize DPP4, interacts with factor 10A to promote further inflammation of adipose tissue and insulin resistance. And that exacerbate the process in heart, skeletal muscles, kidney, pancreas, and everywhere. So the cardiac MS is primarily adiposopathy, as I told you in the beginning, unfavorable distribution. And this disrupts your metabolic homeostasis. And these are the pivotal elements for increased morbidity of cardiometabolic renal disorders with which these patients may have, in addition to MASLD. So you need to have an expanded pathophysiological model that will delineate the interplay of these mechanisms driving the CMRDs. So you have the shared pathways for these, as I've emphasized. So what do you have? When you have weight gain, again, fat distribution, dysfunctional resistant adipose tissue, when initially your triglycerides are stored in your adipose tissue, when the capacity of the subcutaneous adipose tissue is expanded, it gets released into the blood. Once it gets released into the blood, not only a person having some insulin resistance or some metabolic, some other component of metabolic syndrome will have a perpetual cycle of increased lipolysis, more free fatty acid released, and then they go into all these vital organs. So this is the crux of the problem, what you see, and they get deposited in all these organs. Now, getting deposited and the inflammatory process further continues. Now, what happens with the liver? So you also have increased VLDL release in a fatty liver. You have these APO3C containing triglyceride-rich lipoproteins, which are large molecules. They remain in circulation for longer time and thereby lead to atherosclerosis and plaquing. And there is inadequate impaired clearance of triglyceride and impaired lipolysis of large particles to small particles. So this cycle continues, and that leads to MASLD and ectopic adiposopathy. So if you sum it up all, what you find pathophysiology of cardiac MS is, this is what I talked about: environment factor, genetic factor, decreased peripheral adipose tissue, decreased expandability of your subcutaneous tissue, increased free fatty acid. They go into muscle, decrease the glucose uptake. Hepatokines are everywhere. They cause epicardial adipose tissue expansion. They cause MASLD and the gut, the bile acids, microbial metabolites, hepatokines, and the increased adipose tissue, increased ectopic fat, and then it leads to pancreatic steatosis, beta cell dysfunction, diabetes, dyslipidemia, and finally also in the kidney when there is extra fat deposition. So we know now, we try and see some of these associations. So in, causality association, causality, to define causality becomes different. A lot of studies show about association, but causality is difficult to find. And what we found that if there is accumulation of renal fat deposits, it may contribute to renal damage in addition to all other factors which are causing renal damage. And this perirenal adipose tissue and renal sinus fat are compartments of visceral adipose tissue. So what do? So they primarily do two things. One is compression. So once you have that deposition, it will compress at the hilum, compress your vessels and prevent proper flow, congestion, and thereby kidney damage. And so you will have renal flow, you will have a decreased renal blood flow, increased activation of system, hypertension. You will have, on the other hand, free fatty acids, inflammation, decreased nitric oxide, further leading to inflammatory cytokines, leptin, increased sympathetic activity, and cardiovascular risk and endothelial function impairment. So another study which they looked into a renal tamponade hypothesis, they found that once you have this area compressed because of excess fat, as you see here, you would have, this is the kind of decompensated state instead of the normal vascular pathology here, or this is the kind of nephron you will have. So fat around the kidney is bad, and the renal complications are not only because of that. There are metabolites from liver, like you have inoxyl sulfate, you have the TMO, another liver-derived metabolite from trimethylamine, and this is what it is further causing. So you have a person with PLA3, you have TMO from the kidney, you have this kind of a diet, you have NFLD, you have uric acid accumulation, production of the dysbiosis, endoxyl, and all these. They cause further fibrosis and kidney damage in these patients. And this is proven in a lot of studies. So they looked into what was the role of when there was a high perirenal adipose tissue. The patients had albuminuria. Patients also had significant, and this spread improved after sleeve gastrectomy. In a lot of patients, this improved. In addition, it was associated with significant aortic atherosclerosis, renal and aortic, and diabetes and prediabetes. They were much more associated with increased accumulation in the fat. So we also know about diabetes and CKD and MASLD, and this is another study where they looked into 4 things: oral glucose tolerance, MRI measured body fat distribution, liver fat content, and genetic risk in a patients who are at increased risk for type 2 diabetes. And they could identify 6 different phenotypes. And what did these 6 phenotypes showed? The 2 subgroups were marked by elevated visceral adipose tissue and MASLD, and interconnection of type 2 diabetes with ectopic fat deposition in liver and surrounding kidneys. Another thing is about pancreatic steatosis. So we know that there is an alternate pathway for fatty acid deposition in the pancreas independent of hepatic triglyceride production. So there is a direct flow of FFA. And this causes negative effects on endocrine, pancreatic function, more so in pre-diabetes, patients with reduced BMI and increased genetic risk. And this is what is beautifully illustrated here. So if you have an individual who has healthy metabolism and will have a normal insulin secretion once the FFA, free fatty acid, comes here and fat deposition is minimal. On other hand, if you have an individual who again have no pre-diabetic milieu, low fatulin A, even if the fatty acid go, they will still produce a normal secretion. But on other hand, if you have individual with lot of fat in the pancreas, what you will have is these adipocytes start acting through TLR4, and then they activate the cytokines, cause pro-inflammation, and there the insulin secretion further decreases, and they develop pancreatic steatosis. Cardiovascular and MASLD very well know that they can produce all kind of cardiovascular disease with this. This again a biobank study was looked into cardiovascular mortality, and adiposity was found as one of the important cause for cardiovascular poor outcome in these patients. Another study where they looked into genome-wide association of around liver fat measured by MRI, around 34,000 UK biobank studies, and they looked into 13 genetic variants. So they found that they have these increasing alleles. They cause enhanced lipogenesis, impaired fat export, so high liver fat, and produces all these kinds of complications in these patients. So FFA can also cause directly endothelial dysfunction. As I told you, you have high triglyceride-rich lipoprotein molecules. They do not settle, keep on circulating, and can produce that. But by other mechanisms, because of the paucity of time, I'm not going into that. You have reactive oxygen species, you have insulin resistance, you also have decreased nitric oxide. So all these manifestations may occur with increased free fatty acid. Now adipose tissue in the heart. So we know that in the body in the earlier age, whatever adipose tissue, you have a lot of brown adipose tissue, which is healthy. But it is subsequently that the white adipose tissue takes over, and then that becomes pro-inflammatory, apoptosis occurs, and this causes all these pro-atherogenic and pro-atherogenic scenarios. So look at this, the study where they looked into free fatty acid affecting the cardiomyocyte. And when they looked into that, they found that free fatty acid decreases the cardiomyocyte continuity, and all these factors get activated. And these people become, you know, when you look into atrial myocardium and left atrial ectopic adipose tissue, this is what happens. They start getting arrhythmias. Similarly, if you have heart failure, the myocardium and epicardial adipose tissue, again free fatty acid, and the perpetual cycle will produce worsening. And how do you judge this EAT? Echo is a good site to do that, but the limitation is it is 2D and inter-observer variability. You really need to, if you really need to find out complete fat profile of the heart, you need to do a 3D imaging, or you need to do an MR or a CT. So this is what various imaging one can do. And we have now studies which have documented improvement in this fat when these patients were treated with these GLP-1 agonists, SGLT2 inhibitors, and they've been documented. And look at this percentage change in epicardial adipose tissue. It is gone up to 42% from 10 to 42% change in epicardial adipose tissue while using these drugs. So there cannot be any talk without gut-liver adipose tissue combination causing this problem. And we do find that urobilinogen and bile acid products are elevated in patients with cardiovascular disease. In this study, they have shown that if you have if you have hyperbilirubinemia, or you have hyperurobilinemia, an obese or a normal, these all would lead to cardiovascular morbidity and mortality. Similarly, at the right bottom, if you do the transcriptomic multi-omic analysis of the microbiota, you find that patients who are having visceral adipose tissue protobacteria were negatively associated with insulin sensitivity. Having said that, how do you evaluate this syndrome? So if there is adiposity, we generally are doing DEXA. We are doing also body composition analysis. Yeah, and also looking into BMI and hip fat circumference and ratio. That's good enough to begin with initially. But if you have clinical suspicion, please do a TSH, or if you are thinking of a Cushing's, do a dexamethasone, and also polysomnography, which we generally don't do. If you have insulin-resistant diabetes, we are doing most of this, what is related on the left-hand side, including HOMA-IR, and it should be done in these patients. In case you have arterial hypertension, and if you are not able to document on one reading, subject them to office and homebound recording. And also ABP, if there is a lot of fluctuation, is important. Also look for secondary causes if it's not getting treated with 1 or 2 drugs. If you have dyslipidemia, advanced lipid profile, we are doing that ApoB1, ApoB. May need to do some genetic testing, and it is being done here as well. If you have CKD, you are doing eGFR, we are doing serum creatinine, we are doing UPCR, but sometimes you would require some special tests like autoantibody workup, genetic testing in patients in whom we are not able to discern what is the cause for it. If you have MASLD, we are doing FIB4, we are doing fibroscan, and maybe an MRI and biopsy in selected cases. For cardiovascular assessment, is that just doing ECG and echo is not good enough. You need to look into stress testing, if you can do that. Also look into vascular imaging. And if patients have heart failure evidence, try and look for some hormonal things which we never think of, growth hormone, testosterone, or T3 deficiency. Also look into the reproductive organ system, which we generally do not do. So look for PCOS, serum hormone levels, and you may do some imaging for these patients. And then you can grade them according to this new definition. It is stage 1, stage 2, stage 3, or stage 4. Stage 1 is primarily weight gain and dysfunctional adipose tissue. So how do you know that? You know that by waist-hip ratio and all this. You know by unfavorable body fat distribution. You know stage 1B is when there is ectopic fat deposition in these organs. So most of your patients are already stage 1B when they come to you. Stage B, 2 is metabolic risk factors and markers of risk are present. There is impaired glucose tolerance. There is MASLD, already stage 5, F0, F1, subclinical atherosclerotic cardiovascular disease, and there is mild CKD. Stage 3 is significant cardiometabolic renal disease, what has been defined by AHA. You have diabetes, advanced MASH or MAFLD, fibrosis stage F2, F3, and subclinical and moderate CKD. And stage 4 is, of course, advanced cardiorenal liver metabolic disease, which I'm talking about. So only caveat from the guidelines given is that here the waist-hip ratio is 0.95, and the fat mass ratio, that is between truncal and lower limbs fat, FMR is more than 1.7 in men and 1.2 in women. It defies this cardiac metabolic syndrome in these patients. So do we include MRI in all MASLD patients? Probably it's not feasible right now at the moment because it's expensive. But yes, if some patients can do it, we should do that. But what MRI would you do it? Would you look for abdomen, for fat in pancreas, fat in liver, fat in kidney, and you do something for heart or something for muscle, or do these biomarkers, which we have been doing for a lot of time, which do indicate some possibility of extra fat deposition, but they are not perfect, as we know. So this is the therapy what you propose, that do we now need to give these patients these drugs which are available to us? SGLT2, GLP-1 and GLP-1 combination, resmetirom. So if you have these conditions, you would think, and a lot of trials have already shown results of improvement using these because of positive time for not. So if you have obesity, you start using GLP-1. If you have heart failure with reduced ejection fraction, in addition to ACE inhibitors, ARNI, beta blockers, you do add SGLT2 inhibitors. If BMI is more than 27 in them, give them GLP-1 analogs. Heart failure with moderate rejection or preserved ejection fraction, SGLT2 and finerenone. If you have atherosclerotic carnivore disease, again use SGLT2 and GLP-1. If you have diabetes or no, only BMI, again GLP analogs can be used. If you have, so similarly for diabetic with CKD, and similarly if you have MASLD, you would continue to treat them with, in addition to what you're treating, the associated conditions with resmetirom and GLP-1 analogs. So this is the holistic approach you need. Most of the time it is being done. I mean, at a lot of places, I do get a lot of patients referred with MASLD or fatty liver to me with diabetes or hypothyroidism. So we need to really relook and do a complete assessment and do these management. So why is this needed? Because the current healthcare is generally in siloed care. They may be under-testing or over-testing sometimes. There are conflicting treatment recommendations, although their guidelines are now emerging. A patient gets exposed to polypharmacy, so you may have medicine errors and risk, confusion and poor adherence into treatment plans, and there will be a continued disease progression and poor outcomes in these patients. And what is needed is unique healthcare system and professional societies. Already the guidelines are there, multidisciplinary team of specialists. All aspects of this syndrome are evaluated and managed collectively. Structured fellowship and subspecialty training programs, maybe 3 months training on metabolic syndrome or something like that. The way forward is stage 1 and 2 fatty liver on ultrasound, maybe hit early at heart. Stage your MASLD patient or MAFLD patient according to the new staging which I've shown you, cardial MS. You can measure organ-specific fat in addition to overall fat for staging. Maybe more rigorous cardiac evaluation in these patients involving all other specialties, and develop a treatment algorithm for each subject. And is there a role of bile acid reduction therapy in future? It is emerging. It may also come. And you need to develop an algorithm for our patients in ILBS. Thank you very much for your time.